This is the second case in a series on vertigo from the neck. The ENT diagnosis of vertigo was benign paroxysmal positional vertigo from otolith migration of the semicircular canal. However, it is clear from the patient's medical history that his vertigo was caused by a traffic trauma to the neck. After all, we diagnosed central paroxysmal positional vertigo via blood circulation disorder in the brain and changed the prescription for improving cerebral circulation, which was slightly different from the previous medications, and the vertigo was completely cured. This patient is a man in his 40s. He was undergoing treatment at another orthopedic clinic for an injury to his cervical spinal cord caused by a traffic accident. His symptoms were numbness in both hands and legs that had continued after the accident. The orthopedist had instructed him not to move his neck for 3 months. 2 months after the accident, vertigo appeared when he turned over in bed from side to side. The vertigo lasted from 30 seconds to 1 minute. Other symptoms were accompanied by strong nausea, sweating, a feeling of being out of consciousness, and a foggy vision. He was told by a nearby ENT that he had benign paroxysmal positional vertigo and was prescribed medication, but this was completely ineffective. Then, he was referred to our hospital. The nystagmus findings were the same as those of benign paroxysmal positional vertigo, but as I will show in the following slides, the patient's subjective symptoms suggested a neck disorder as the base cause, and eventually the vertigo was thought to be caused by the brain, not by otolith origin. The treatment consisted of diphenyl hydrochloride, an anti-vertigo medicine, ifenprotyl tartrate, a drug that improves cerebral circulation, especially in the vertebrobasilar artery, and a campo medicine, and his vertigo disappeared completely. This case was treated as benign paroxysmal positional vertigo by a nearby ENT but did not improve. However, the neck involvement is obvious from his medical history. He had a feeling of being disoriented. In fact, this symptom alone can rule out vertigo from the ears. So why the brain and not the ear, i.e., central? It is easy to understand this by first listening to the subjective symptoms. 1. The symptom of faint feeling is due to poor blood flow to the brainstem ciliary body, which is located in the brainstem. 2. In this case, the vertigo was accompanied by severe vomiting and sweating. Benign paroxysmal positional vertigo caused by the inner ear does not cause severe vomiting or sweating. Strong vomiting suggests a central cause. 3. The patient also complained of a foggy appearance. This symptom is caused by poor blood flow to the vertebrobasilar artery. Based on the above subjective symptoms, vertigo from the ears can be ruled out, and vertigo from the brain can be determined. Then why is there such a close relationship between the neck and vertigo? The most common problems in the neck are cervical deformity, straight neck, and kyphosis. In this case, the neck trauma, cervical spinal cord injury and the subsequent 2 months of neck rest had resulted in a state of tension in the cervical muscle group. The sympathetic nerves surrounding the vertebral artery stimulated by this tense cervical muscle group are always in a state of easy excitation. In other words, it is easy to become excited by even a small amount of stimulation. However, this situation still does not cause vertigo. But, when triggering factors are added, such as turning the neck around, sudden changes in head position, or stress, the sympathetic nerves around the arteries become more excited. This causes the vertebral artery to constrict and the flow of blood becomes stagnant. As a result, the vertebrobasilar artery is in a state of blood flow failure. It has already been proven at Nara Medical University that the brainstem and cerebellum, the central organs of the brain, are more vulnerable to poor blood flow than the inner ear. So functional decline occurs before the inner ear, resulting in vertigo from the brain. Furthermore, the same vertigo occurs regardless of which part of the inner ear, brainstem, or cerebellum is dysfunctional, resulting in the same directional alternating nystagmus as in benign paroxysmal positional vertigo of inner ear origin. Therefore, as mentioned earlier, this patient is not necessarily benign paroxysmal positional vertigo. It is a diagnosis of central paroxysmal positional vertigo from the brain. Finally, please subscribe to Dr. Nakayama's Vertigo channel.